We welcome you to this Elder Justice Initiative webinar on assessing cognitive capacity in elder abuse cases. As with all technology, we may at some point today experience a momentary lapse in the webinar session. In the event of a problem, please be patient and remain with us, and the webinar should resume shortly. I do want to take a moment here to see that everyone is connected. If you are experiencing any type of technical problem, please type a private chat message to the technical specialist, Jason, in the feedback box. That's the chat pod on the lower right. If you cannot access the chat, you can also send Jason an email at jadams@ovcttac.org. If you have questions that come up throughout the webinar for our presenters, or you have any sort of technical problems, please type them in the chat box. We will take time at the end of the webinar to address any questions we have remaining. And also note that today's session is being recorded and will be made available on the OVC TTAC training website and also the Elder Justice Initiative website. So at this time, I'm going to turn things over to our host, Talitha Guinn-Shaver. She's the MDT Technical Advisor with the U.S. Department of Justice. Talitha.
Thank you very much, and welcome everyone. Very happy to have you here with us today on Eclipse Day. I hope you get a chance to take a peek at some good eclipse footage, if not experience it in person later on today. Today we're going to have a really great presentation about assessing capacity in cases of elder abuse. I'm going to quickly run through a little bit of information about the Elder Justice Initiative and our new multidisciplinary team technical assistance center, and then we'll jump into Bonnie Olsen's portion. It's going to come in three parts: case context, where capacity is an issue, the components of capacity assessment, and the client-centered perspective. We have a lot of content to get through today, so we are holding questions to the end, but feel free to drop your questions into the chat feature at any point that you have a question come up. So we start really quickly by asking everyone a little question here about your professional background. So if you can let us know who's on the call today, we can sort of tailor today's conversation to best fit your needs. And it looks like we have lots of social workers here with us today, some legal representatives, victim services, administrators, some law enforcement. Hi, law enforcement. Always nice to see you, and others. So thank you for jumping in and letting us know who you are, so we can, like I said, tailor the conversation a bit to best suit your needs. So I want to just back up and talk a little bit about the Elder Justice Initiative. Since you're on the webinar here with us today, you probably know a bit about the work that we are doing. But we really strive to promote justice for older adults, help older victims and their families, enhance state and local efforts through training and resources, and support research to improve elder abuse policy and practice. If you haven't been to our website recently, I highly recommend that you go check it out. We have a brand new format, and I think it really brings forward a lot of the great resources and free educational materials, free brochures, free webinars, and presentations that you can use in both public and professional settings to teach people about elder abuse. We have some great sections here for older Americans, families, and caregivers, very in-depth information on financial exploitation, really rich resources for prosecutors, including sample pleas for elder abuse cases, and some really wonderful collaborative training materials and videos specifically on the topic of elder abuse tailored to prosecutors. So check that out. We also have wonderful tools for law enforcement, victim services, and our new project, the MDT Technical Assistance Center, has lots of great information for multidisciplinary teams. And we are really here to help provide materials, resources, and in-person or phone consultations. So if you are on an MDT and you're having some issues and you would like a real person to help you work through them, you can actually call and get a live consultation. You can also set up a training in your community to make you aware of that. We also have a lot of educational opportunities, such as today's webinar. And if you haven't checked it out yet, go over to the website and take a look at our newly launched MDT guide and toolkit. It is a very well researched and I think a usable guide. Now it is my pleasure to introduce to you Dr. Bonnie Olsen, who is a clinical psychologist with extensive experience as a geropsychologist working in academic medicine for over 20 years. She provides cognitive assessment and short-term mental health treatment in a collaborative geriatric primary care setting. As the Vice Chair of Academic Affairs in the Department of Family Medicine at the Keck School of Medicine at the University of Southern California, Dr. Olsen is involved in a number of research and program grants that focus on interprofessional geriatric education and elder abuse education and prevention. She is particularly interested in elder mistreatment as it occurs in the context of dementia caregiving and understanding decisional capacity. In 2009, she was awarded the Gold Humanism Honor Society's Gold Star Award for Humanism in Delivery of Healthcare and has remained dedicated to community service throughout her career. Dr. Olsen is a passionate advocate and expert for the prevention of elder abuse and has guest lectured throughout the country on this topic. And I was hoping that Dr. Olsen could sort of start today's conversation by maybe giving us some cases in which capacity might be an issue and when you might want to use an evaluation. Dr. Olsen?
Well, hello, Talitha, and thank you very much for that really nice introduction, and welcome to everybody on the webinar. Yes, I'm happy to give some cases that will help to illustrate where the issues of capacity come into play in elder abuse situations. A number of cases, just so everyone's aware, these are real people who I've had the opportunity to work with over the years. Obviously, I've changed the names, and these are not really their photos, but they're just meant to sort of illustrate. But they are real people who have had real elder abuse issues in their lives. So first off, we have Mr. Jones, who's an individual who had been widowed in about 6 months before I was asked to come out to see him. He had had a stroke, which left him with some mild hemiparesis. He had an engaged family. An adult child of his was involved, and she felt that getting the her grandson, or her son, the client's grandson, involved in his care after he had been released from hospital would be the best situation. As it turned out, however, he did attempt to be a caregiver, but he was observed to physically abuse the client. A bystander witnessed it, and he was then involved with APS and the police and so forth, and it was further investigated. I was called in then to do an evaluation, and in this case, the issue of capacity came in not so much as to whether mistreatment had occurred. It clearly had, but it was really a question about whether the client was able to determine where he wanted to live, who he wanted to receive care from, who he wanted to live with, and what his expectations about safety were for himself. So capacity
I'm
was...
sorry, Dr.
Sure.
Olsen, could we have you speak up a little bit? Some folks are having a hard time hearing you.
Okay, so sorry. Let me see if I can raise volume a little bit. Okay. Tell me if that's better. Is that helpful?
I'll wait for
Hello?
some folks to respond.
Okay.
Is that better? They're saying no.
No. Okay. I'm just going to have to sort of, is that a little better?
Yes.
I'll keep.
Yes.
Okay.
It's a little louder.
All right.
Thanks.
Okay. All right. Thank you for that. I certainly don't want to be talking away with no one being able to hear me. Okay, so for that case, that really was the issues around capacity that I was asked to offer an opinion about. The next case is Mrs. PEREZ, who was a 63-year-old widow, lived alone in her own home. And unfortunately, she had a delusional disorder, believing that her neighbors were poisoning her. And it was quite an elaborate delusional system that was quite fixed and quite rigid in her own mind. She had hired a contractor to install a security system in her home that she was grossly overcharged. At the end of the day, I believe she had paid him over $300,000 for a system that was worth $24,000. Again, this was a case that was prosecuted. And in this case, the question to me was really whether she was able to reasonably evaluate the contracts that she had signed in purchasing the security system. So the fraud occurred because the contractor had capitalized on her vulnerability arising from the delusion. He acted when she was most impaired and really magnified her delusional system so that it increased her vulnerability, instilling fear and greater dependency on him. And through that, he was able to defraud her. So she clearly did not have the capacity to really understand what she was agreeing to, largely because of her delusional system. So then the next case, Mrs. Kim is an individual who was living with her husband, had been married for many years. She was incapacitated physically by Parkinson's disease. And she described her husband as someone who ruled the roost in the home. When I was asked to come see her as through the APS had been involved and asked me to come out and join them for an evaluation. She answered the door and had a black eye. And so there was a lot of questions about what kind of care she was getting and was she being mistreated. It turned out she had had a fall, which resulted in the black eye. But in doing our evaluation, we found that she had really grossly inadequate care. And it was a very complex situation of family dysfunction and violence that had gone on for decades. It was questionable whether prosecuting was the right thing to do and what would be in the victim's best interest. So part of my evaluation was really to help determine whether the victim was able to make her own decisions, accept help or refuse services, as the case may be, and was she able to identify a surrogate decision maker? Was she able to weigh out alternatives and come to a choice on her own? And indeed she was. Ultimately, in this case, what we were able to do is to help to sort of empower both the victim as well as her adult children and help to really put some more stability in the family situation so that she was better able to get her care needs met and in a safe manner. Okay, and then this next case is Mrs. Ellis, who I saw in her home, again, with an adult protective service worker. She had suffered from macular degeneration, which compromised her vision, and she also had some pretty significant arthritis. Those two in combination caused her to take a serious fall where she fractured her hip. After that was treated in hospital, her adult daughter, who lived out of the country, arrived and arranged for her post-acute care back at home. And unfortunately, she hired a caregiver out of the newspaper. And then the daughter returned to her own home. some weeks later, a granddaughter came to visit and see if the victim was doing well and found her to be very compromised, confused, disoriented, and not mobile. She was seen in a recliner chair and wasn't getting up and moving. And the caregiver looked like she was providing adequate care, but the granddaughter was very suspicious because her grandmother had been very alert and competent until she had had the fall and the hip fracture. So she called the Adult Protective Services. What we came to discover in doing the assessment was that the caregiver had been taking her pain medications and either taking them herself or selling them, and we don't know which, but giving the client aspirin instead. She was also very dehydrated and suffering from some significant pain as a result of all that. So we wanted to put a poll out to see if you all believe that this was a case that deserved to be assessed, and was capacity an issue in this case? So I'll let everyone respond. And okay, it looks like the vast majority of people are saying that an assessment is in order and that there is some issue of capacity here.
I think this is a great poll to have for this client because particularly if you're working on a multidisciplinary team and grappling with these complex cases and wondering which services should you provide to this client, which tools should be used, do you need a cognitive evaluation, grappling with these things in the real world can be very challenging.
Absolutely, yeah. This, like many cases, you don't really know what you're going to find until you actually do the assessment. If we can go to the next slide then. Okay. And I think what we found was that this was a woman who had no underlying cognitive impairment, but on the day when I went out to see her, she was clearly compromised by multiple factors that were related to delirium that probably was coming in part because she was so dehydrated. She was also having significant pain and was quite depressed at that point. All of those factors are ones that change over time. They can, be resolved with appropriate treatment, and it really brings up the issue of fluctuating capacity, that until you go and really evaluate and figure out what's underneath, what's the etiology, why is this person so compromised right now, it's really hard to know what the issues are. And as it turned out in this case, once she received adequate treatment, her cognitive functioning was restored. She was no longer confused and was able to really make decisions for herself and had full capacity. So, but you wouldn't have known that the day that we had seen her, where she could barely answer simple questions. So that issue of fluctuating.
This really, this case is so great because I think a lot of multidisciplinary teams deal with cases just like this. So you can have clients that present really well, are really good at hiding their deficits, and when you get in there and do an evaluation, there are some absolute deficits, and they're going to need some support services put in place so that they can, function better or have a better quality of life. And then you've got these clients that you think, oh my goodness, they definitely are lacking capacity, and you get in there and you can realize that these are medical issues that can be resolved. So thank you for showing the array that you might encounter on a multidisciplinary team.
Great. Yeah, I know. It's remarkable how diverse the situations are and how it's so hard to see at the front end and predict what you're going to end up seeing at the end. So, yeah, it's challenging. Okay, I think now we can shift over to talk about how we do capacity assessments and the different aspects to them. So first, I think it's worthy to mention that regardless of what the circumstances underlying the questions that were being asked, there's sort of an inherent tension that we have to address. And it's really the balance between an individual's autonomy versus safety, or their ability to make their own decisions, their self-determination, or our paternalism, our wish to put things in place that will create that safety and security for them. That balance is not easy to achieve, and it's one that I keep really at the forefront when I'm doing these assessments, because every time we put something in place that increases someone's safety, it almost universally means that the individual is losing some self-determination as a result. And that's the cost of the safety often. So keeping that in mind, I think, is really important. There are several forms of capacity, and I think at this point, and even though this field is still quite young, I think most practitioners will agree that there's really a difference between decision-making or decisional capacity and what we refer to as executive capacity. And I'm going to just take a few minutes to sort of illustrate the difference between those two. So in the decisional capacity, there are really four underlying principles that we integrate into the whole question of, does this person have capacity to make this decision? They have to be able to understand the issues that are related to the decision. And this is really just processing the information. Do they really comprehend and understand what's at stake, or what the issues are? And then the second part is appreciating, and that really means appreciating how it applies to oneself in the context of their own lives. The third part is reasoning. Is the individual able to reason and evaluate, look at alternatives and weigh those out? And the last part is being able to express a choice. And in most laws, it's referred to as choosing the thing that's best for oneself. And we, as the evaluators, can't really determine best for the client. That's really the client's choice about what's best for them. But this is really being able to express the choice. So that's the decision-making part. So how does that apply in real life? These are some examples of ways that decisional capacity is applied. It might be signing a contract, whether it's purchasing annuity, or like signing a reverse mortgage, constructing a will, what's referred to as testamentary capacity, giving away your assets, giving away property, gifting things to others, the capacity to get married. In the medical world, medical decision-making might be about taking medications or choosing to have a treatment or not, or whether to leave a facility, perhaps against medical advice. Identifying alternative decision makers is often a question that's posed to me, whether an individual has the capacity to identify a durable power of attorney or a successor trustee or an executor. And probably the one that I hear the most from adult protective service workers is whether the client has the capacity to decline services. Do they really appreciate the impact that will have on themselves and their own welfare? Okay, and all of that decisional capacity is sort of in contrast to executive capacity. And this is what I refer to as being able to actually do things or execute a plan. So an individual may be able to decide, here's how I want to spend my money, or this is what I want to do regarding something else, but whether they're able to actually do it. So this is about being able to implement all of the instrumental ADLs in daily life. You might have the best intention, but if you're not able to actually do it, then you may lack the executive capacity. So now I'll talk a bit about how we do this. I have developed...
Bonnie, I'm sorry we lost you again. Could you
Oh dear.
There you are. There you are.
Okay. Okay. All right. I need to hold the microphone up closer to my mouth, so I'll try to remember to keep that there. So please let me know if it slips off again. I'll do my best. Okay. So this four-step process is really something that I've devised that works well for me. It sort of integrates a lot of different aspects into a process that I find works well. So the first step really is about doing the assessment as to whether the individual is able to process information and think logically. And this is where you do the cognitive testing to measure those functions. I don't have a good way to do this other than actually testing for it. It's sometimes tempting to assume that the person is doing all right in that domain after having a conversation with them. And I can't tell you how many times I've been fooled thinking that someone has good cognitive functioning only to do the testing and find out that's not the case. So most cognitive assessments include all of these domains of functioning, including, as you can read here, attention and concentration, long and short-term memory, language functions, visual spatial skills, reasoning, and executive functions. Executive functions I put separately here on this slide because they're so complex to measure and they have such a huge impact on people's functional capacity in their day-to-day lives. This is often I describe this to families and patients when I'm working in a clinical domain. This is really the function that allows us to match our behavior to the situation we're in the moment, and to organize and plan and to weigh out alternatives and come up with a plan that makes sense and to actually implement the plan. So those are all functions that fall under this domain of executive functions. This is a short list of some assessment tools that are used commonly. The first one is really a neuropsychological test battery. That's often a group of tests that are used together that really take a deep dive into cognitive functioning. And sometimes we have the ability to do that, and sometimes it's just not realistic. The balance of the tests on this list are shorter versions that are more considered screening measures, and they may take somewhere between 5 and 15 or 20 minutes to administer. And they all have strengths and limitations, but and I can't say one's better or one's more appropriate than another, but they're all used in this context in different settings. So I think we're going to take another poll question here. Talitha, you want to pose the question to the group?
Sure. So thinking about doing a cognitive assessment, is it important to use a test that generates a score in order to have a good assessment? I think this is something that comes up a lot with multidisciplinary teams as well. Okay, we're going to do an assessment, but what is it going to mean? What kind of a test do we need to do, and how do we interpret it, and do we need a score? It looks like most people are weighing in with yes. It is important to have a test that generates a score. Do you want to touch on that a bit, Bonnie?
Sure, yes. And I think the answer to this question in my mind is it depends. There are times when there's a definite benefit to having a score on a test. It allows you to compare one individual to the general population or to other individuals of their age and educational level. And that could be really beneficial. I'm going to go back one step there. The other thing it does is when you have a test score is it allows you to compare the individual to themselves over time so you can see change. So if you do administer the same test at 2 different points in time, you can see, oh, has the person functioning declined or actually has it gotten better? But there are times when, and different individuals who do assessments, that they may not actually generate a score, and it doesn't mean that they haven't actually assessed memory and language and all the domains of cognition. Particularly, I've seen many reports that are generated by, say, geriatric psychiatrists that may not actually have a test score, but they've done a very adequate job of assessing the individual's cognition and can speak to how that person's cognitive functions are doing without it having the score. So while there's benefits, there may not, I would caution you to think that that might not mean it's not been adequately measured. So depends on the situation. But moving on, the second step that I would encourage you to use or to apply in doing a capacity assessment is to really look at these other areas and domains which fall more in the psychiatric range, more like mood disorders and hallucinations and other perceptual disturbances and thought disorders and delusions, similar to the case I brought up earlier of Mrs. PEREZ, who had this real fixed delusional disorder. It's important that one doesn't just assume that if someone has a disorder such as like a dementia, that these other kinds of deficits may also be there, compounding the problems. So particularly when we see folks who have dementia, there's also often, in addition, depression, further compromising their capacity.
Mm-hmm.
The next step is really taking a deep dive into the actual decision. And what I have here on the screen is really the sort of steps or the components of that. You want to be able to interview the individual to kind of get a feel for whether they're able to reason through what decision they're making. Do they understand and appreciate the consequences of this decision? How will it benefit them, or what are the risks that might come as a result? What other choices did they consider? And then again, how consistently they hold this choice in mind. Often I'll ask the client what their decision is at the beginning of the interview, and then I'll ask it again at the end to just make sure that there's some consistency here. And again, in doing this, particularly this aspect of the assessment, it's important that it's really clear what the decision is. Capacity assessment isn't a global measure. It's really about a particular decision at a particular point in time. Currently, there are a movement in the field towards using more structured interviews or semi-structured interviews to complete this piece of the assessment. One that I like particularly is the called the ACE, which is a structured interview that's been developed recently by Dr. Kurlewicz from University of Pennsylvania. So that's something that I think really helps to get to this aspect of the assessment. And then step 4 is integrating all the other sources of information that puts the context of the individual into the equation, if you will. So I want to really find out information from collateral sources, whatever those might be, including family or caregivers, adult protective services, sometimes medical reports, or if the police have been involved and are doing some investigation. I want to really understand this individual's values, beliefs, and preferences over time, historically, both how it was in the past and how it is now. And it requires really doing a good interview to understand who this person is and what's important to them in their life. I want to consider their own personal cultural background, maybe religious background, and also the culture of the family that they come from. So often in these cases of elder abuse, there's a very complex family culture that may include domestic violence in the background or other particular things about how this family has functioned that may have created the risk for the mistreatment to take place. And then lastly, I want to know if there has been any effort to enhance this individual's capacity. This might be doing things that help to put some support systems in place so that whatever their vulnerability or their limitations are, has there been something done to help sort of shore that up, which might be some good caregiving. It might be something simple like, did you try to get them hearing aids? Something simple like that can make a difference in an individual's capacity. I want to be able to assess the level of risk. So if we don't intervene and we feel this individual retains the capacity to make their own decisions, then what lies in the balance? What are the risks to the individual? Will this result in some significant harm? Or is this a risk that is worthy of bearing so that this individual can retain some autonomy in their daily activities? This slide, I think, is, for me, particularly helpful. This comes from the assessment of older adults with diminished capacity, which is a handbook that was published, I believe it was in 2008, so it's had some years of use, and I think it's stood the test of time at this point. It was developed by a conjoint work between the American Bar Association and the American Psychological Association, and this one slide really puts all those different pieces together into sort of one whole that really helps you to weigh out all the different parts before I'm willing to offer an opinion about capacity. So it really helps me to integrate all the pieces together. So those are sort of the nuts and bolts of how we go about performing a capacity assessment.
Yeah, thank you for that, because it's so important to know what are the elements that go into a good assessment, and if you have requested an assessment from an outside practitioner, what to look for when you're reading the assessment. So thank you for that. I'm wondering if you can tell me how all of those pieces apply to case management.
Well, there's what's difficult is then taking the issue of capacity and then applying so what are we going to do for this individual? How are we going to intervene? What's going to make sense in this individual, in this situation? What I think is really, really important and becoming much more talked about and recognized in the field is how important that we keep a client-centered intervention in mind, that we have to really value the client's values and preferences. I think we need to make sure we consider cultural issues so that whatever we're suggesting to intervene, that it's culturally sensitive, it's meaningful to the individual, and it's the least restrictive intervention possible. These are not always easy to do, but I think we're, as a field, we really need to be compelled to make sure we work in that direction. So how do we do that? It's tricky. It's not easy to get that balance right. How I try and do that is to really listen to the client, listen to what they want, what's important to them. And if you ask, most of the time you can hear from the client what the important things for them are. I want to really pay attention to what their historical preferences are. I mentioned that earlier. If I see a big change from what it once was to what it is now, I really want to go and look at and figure out what's driving that change. For instance, if an individual was someone who had always been very social and engaged with friends and activities in a social way, and now they're ostensibly looking like someone who's preferring to be alone, not engaged in with others in a big way. I want to really understand why that change has occurred, so that I can understand whether that's due to their disorder or disability, or is that really coming from something like depression, something that really should be treated, and then we can try and restore what had been their historical preferences. Whenever I can, I want to align my goals with those of the client, and that takes some real effort. Sometimes it's not possible because sometimes the client's goals are really not safe, but sometimes they are, and if we can find those even in small ways, I think we can do a better job of serving our clients. Some of the things I try to do is think about what would happen if we didn't intervene, or what would happen if we tried this, which may not be quite as drastic a change as we might want to do to really restore full safety. We want to make sure we avoid unintended negative consequences. This has been something that's been talked about a great deal in terms of interventions with elder abuse, that we often intervene with the best intentions and we end up creating a situation that's almost worse than it was before we arrived. We want to build in relatively safe choices for the client. So if they have lost some capacities, almost everyone, even the most demented patients, can retain some capacity to make some safe choices for themselves. And I try to think about what's most important to this client. And sometimes it's the little things. So, for instance, even individuals who may have very little capacity left in the range of managing their own finances, sometimes they can still manage small cash transactions. And I might write into my opinion for the court that this individual deserves to have $20 in their pocket so that if they can go out and buy something. It might be that they be able to decide what they eat or when, or who gets to visit, or attending church services, or when they take their medications. One thing I hear often from clients is they don't want to go to a facility because they're going to be on this regimented schedule, and this is someone who is a night owl and didn't want to get up at 6 in the morning but wants to sleep until 10, and it's disruptive to the facility staff. But if we can find ways to build that in and those choices into their life, it can be extremely meaningful. I really encourage and want to inspire you all to think outside the box. If you can find possibilities and potentials, little things that can matter greatly to the client to make decisions in their own lives or have the things in their life that matters to them, then it can restore a lot of that self-determination that they can still manage and have it be safe. So sort of in closing, I want to say that our goal should be to provide the right resource to the right client at the right time in the right amount, and sometimes it might be less than what we'd like. So I'll stop there and see if we have some questions.
Thank you, Dr. Olsen, for that really wonderful overview. And you're so right thinking about what our end goals are, and really to make sure that we are helping that client have the highest quality life possible and maintaining some sense of autonomy where it's possible. If anyone has any questions, you can drop them into the chat feature, and we have about 10 minutes here where we can take questions from the audience. Looks like there are a few people typing. I'll just jump in here and say that in my previous job, I was the director of the San Francisco Elder Abuse Forensic Center, and one of our great challenges was really figuring out when to have psychological evaluations, when to assess capacity. And that piece that you brought forward about really understanding what you're assessing for and making sure that you're writing that into your assessment was of great value when something went forward, if it did end up going to court. Really looking at that domain where the question has come forward in the case review.
Yeah, and in my experience, what's been really helpful is when I was involved with a forensic center, as a group, we could sort of process through the issues of the case and formulate what is the question, what's the capacity question that is central to sort of moving the case forward, what's going to help us figure out what the next step is in this case, in managing the case.
Right.
And the group process is so helpful. It really is.
Yeah. We have a couple of other questions coming in. First one is, I'm wondering how others handle conflicting scores with capacity assessments. Do you have any thoughts on that?
Yeah, so often this happens, that the same test might be administered at 2 different times, and you might end up with 2 different scores because the patient's capacity has changed. It fluctuates. It may be that you're comparing 2 different test scores and trying to make sense of how these 2 scores relate across, and it's tricky. Sometimes it's a little bit like comparing apples and oranges. If you have a clinician that you're working with, a practitioner who is administering these, it makes sense to talk with them about that and get a good sense about what those scores are telling you. The score itself is just a number. The score on a test doesn't tell you their capacity. It is only a piece, as we've just spent some time talking about. So that in and of itself is not the capacity. It's interpreting it in the context of the situation that's at hand.
Right.
So and I think that sometimes those 2 different scores, sometimes you can come to some understanding of what that means, and hopefully arrive at a plan of action that makes sense for that client.
Sure. Another question that came in was from Kelly Luna, and the question is, what if it's determined that a client has capacity but wishes to remain in a violent relationship in the home? And we did have a bunch of other webinar participants jump in and talk about working with domestic violence advocates and referring them to DV specialists. Do you have any other thoughts from the clinical perspective?
Yeah, I think this is one of the hardest situations for all of us, because the last thing we want to do is to walk away from a situation where someone is clearly being mistreated and feel like our hands are tied, that we can't.
Can you use your mic again?
Sure. Is that,
there you go.
Is that better? Okay. It's very upsetting. It's very difficult to sort of come to terms with those situations. But indeed, if the person has the capacity to make that decision.
Bonnie, we lost your audio. I think Bonnie's having just a problem with her mic, so we will come back to her in just a moment. I had another question from an APS caseworker wondering if there were going to be links to the other tests mentioned, and I will look for some of the tests. Some of them are not available online, but where they are, I will include them in the thank you email that goes out to everyone who was registered. Bonnie, are you back with us? Can you hear us, Bonnie? We can't hear you. Okay, are there any other questions that are coming in? Question, can I get a copy of the transcript when they're available? Yes, there will be a link to this webinar, and you will also be able to download a PDF copy of the presentation. Bonnie, are you back with us? Okay, I think we're having just a few technical issues there. But we are at the end of our questions in any case. So I will go ahead and put my contact information up on the presentation. If you have questions about this presentation, or if you would like to contact the Multidisciplinary Team Technical Assistance Program for ideas around collaboration, or if your team would like a consultation, you're welcome to give me a call or an email at any time. I want to thank everybody for your participation on today's webinar, and I hope that you all have a wonderful, happy Eclipse Day, and thank you for sharing your time with us.